you, everyone. We have a good 2-hour session, and I'm so delighted that I can see people from academia. I see clinicians, I see students, I see people from all over the continent and beyond who've joined us on this webinar. We have a very, very sharp and eminent panel across the continent. We have people joining from Zambia, Ethiopia, there's somebody in Rwanda who's South African, we have Kenyans, we have Ugandans. So it's a very diverse and a totally continental panel that's going to discuss a topic that is very critical to us, which is blood. Like Samira mentioned, the Coalition of Blood for Africa, which is powered by Africa Health Business, is indeed very proud today, ahead of the World Malaria Day, to bring to you this important webinar that will discuss insights and will discuss solutions and potentially keep this conversation going. Africa CDC is going to give us a keynote address, which will set the continental strategy and leadership that we'll be looking for. Members of the COBA, which is a coalition of Blood for Africa, include Terumo BCT, Roche, B Medical Systems, and Damusasa. These 4 organizations put in place the thrust that we really need to discuss about blood. AFBST and the Global Blood Fund, Ministry of Health Kenya, have also been an integral strategic partner to allow us to move with these blood discussions. Why did we discuss about blood? I think when we talk about malaria, you really can't disconnect the matter of blood and malaria. So on my next slide, as we move, I wanted to talk a little bit about the scourge of malaria. And I mentioned this before. Which one is more deadly, the mosquito or the shark? The deadly shark has killed just over 1,000 people in 100 years. But the mosquito actually kills over 1,000 people just in one day. 50% of the global malaria deaths is accounted for in these 4 countries. And I really want you to see Nigeria, DRC, Uganda, and Mozambique. Of course, there are many other countries who do get hit by the disease malaria. But these 4 countries, we need to have a special focus. And if you look at the numbers, they are really startling high. We haven't really made a difference. 21, 22, how many people have actually died of malaria? Over 600,000 deaths, 240 plus million in Africa. 94% of all malaria cases and 95% of deaths arise from the WHO African region. And children under 5 are most susceptible. And we have a pediatrician with us who's going to give us an experience about how children really suffer the scourge of malaria. I am really delighted that as COBA, we have been able to bring this engagement on malaria and interlinking that with blood in this webinar. So I will briefly just talk about COBA before I bring on the panelists. So on the next slide, I'll tell you what is COBA. COBA has its vision and its mission and its structure organized. It's a relatively new coalition. And partners across Africa are now beginning to come together with a common purpose, because we believe collaboration is the new innovation. Many of these institutions are from the private sector. Some of them are from the NGO space, and we also have the public sector institutions that are coming on board. So this coalition is a unique platform of non-state actors that have unified towards adequate, safe, and sustainable blood. Our mission is together saving lives by enabling sustainable access to safe blood in Africa. And we really look forward. Oh, it's an inspiration. It's actually a desire to have 0 deaths from lack of blood. Having said that, I think it's now time for me to bring in our keynote speaker. On our next slide, as we move on, I'm really delighted to actually introduce Hannah Emmanuel Tesfahouné. She's the Technical Officer, Endemic and Neglected Tropical Disease in Africa, CDC. We all know that this very young institution, who is 7 years old, has done tremendous work in galvanizing continental strategies. During the pandemic, we gave you accolades in saving lives and saving livelihoods. Since then, I've seen so many initiatives led by Africa CDC, such as the vaccine initiative. I've also seen the pharmaceutical manufacturing initiative. I have also looked at the digital health architecture that Africa CDC is leading. I really want to open the floor for Hannah to tell us about Africa CDC's mandate and tell us a little bit about where you see blood in your agenda. The attendees that have come today, the partners that are involved with us, want to work with you as you lead us and spearhead this neglected item of blood, which can save so many lives on our African continent. Ladies and gentlemen, please welcome Hannah to the stage. Hannah, over to you. Thank you for giving us your time.
Thank you so much, Dr. Amit, and good afternoon, everyone. Today, I'm here on behalf of Dr. Mohammed Abdulaziz, the Head of Division of Disease Control and Prevention of Africa CDC. And I stand before you today to address a topic of utmost importance, the role of blood in the management of malaria in Africa. As we gather here to commemorate the World Malaria Day, it is very crucial to recognize the significant burden that malaria continues to impose in our continent. And Africa CDC, with its mandate to safeguard the health and safety of its people, is at the forefront supporting its African Union member states in their efforts to combat this devastating disease. As you observed from Dr. Amit's presentation, in 2022, Africa bore the brunt of the global malaria burden, accounting for a staggering 94% of malaria cases and 95% of malaria deaths worldwide. And 4 African countries alone, Nigeria, DRC, Uganda, and Mozambique, contributed to over 50% of the malaria death. This calls for a concerted efforts and strategic interventions to address the challenges faced in managing malaria. Africa CDC recognizes that severe malaria anemia poses a significant threat to the lives of those affected by malaria, particularly children under 5 years old and pregnant women. And to address this critical issue, Africa CDC is collaborating with the Coalition of Blood for Africa, who is bringing together stakeholders from public, private sectors, research, academia, and civil society in order to ensure the safety and availability of safe blood for transfusion. In our latest strategic plan, Africa CDC has introduced high burden disease, has included high burden diseases such as malaria as one of its key priorities. And this strategic plan places emphasis in the strengthening member states and regional health systems to effectively prevent and control these diseases. And currently, Africa CDC's Division of Disease Control and Prevention is developing its internal strategic priorities for endemic and NTDs, including malaria. And these priorities will be to support the full implementation of the objectives outlined in the overall Africa CDC strategic plan. They will also identify innovative strategies, technologies, health system approaches for diagnostics, treatment, and management of this devastating disease. In our commitment to blood safety, Africa CDC will also leverage on existing flagship programs and initiatives like the Community Healthcare Workers Initiative to educate communities about the safe blood donation practice and the importance of regular donations. And through our other initiatives, such as digital health system strategy and initiative, will leverage digital tools to enhance blood supply chain management and ensure safe transfusion practices. Additionally, we'll strengthen blood safety measures by leveraging on the local capacity being built through the PAVM initiatives. As you can all agree, ensuring a reliable blood supply is one of the key challenges in health emergencies in Africa. And Africa CDC, in line with this mandate to safeguard, will collaborate with stakeholders, explore opportunities, and address challenges. We will advocate for policies, initiatives, and strategies to address the blood safety challenges and raise awareness, emphasizing the crucial role of blood in managing malaria for those with severe malarial anemia. To conclude, Africa CDC remains committed in addressing the challenges associated with malaria management through coordinated collaboration, and with partners, we are striving to strengthen disease management, raise awareness, and establish collaborations that save lives. Let us join this momentum and work in cohesion to enable sustainable access to safe blood in Africa. Together, let us make a lasting impact in the fight against malaria and create a healthier future for all. Thank you. Over to you, Dr. Amit.
Thank you. Thank you so much. I give you an applause. I give you the real accolade towards making the lasting impact. I'll take your words on that. I'll also appreciate the fact that you're saying Africa CDC remains committed. Africa CDC believes in collaboration. And Africa CDC believes in partnership. In fact, your new public health order really spells out action-oriented, respectful partnerships. And under that pillar, you see many of us present today on this webinar who have been attending and are going to speak, are partners committed to work with you. One key point I do want to talk to you about is the health security and preparedness of the African continent. It's become a key priority, Hannah, for you and your leadership to ensure that should we have emergencies or another pandemic, we are more well prepared. Just tell us in a few words what we should be expecting in the next few years on better preparedness on emergencies from Africa CDC.
Thank you so much, Dr. Amit. And I just want to also emphasize one of the very key pillars of Africa CDC's new public health order is respectful, action-oriented partnership. And that is what we are all here to do today. And with regards to the question, yes, one of the support we will be providing is through the strategic priorities that we are developing in very close consultations with our member state experts as well as different partners. We're very cognizant that there are different organizations that have been supporting our member states with the malaria, and we are working very closely with them to ensure that our efforts are not duplicated and they are yeah.
Thank you. I am really looking forward to it. You know that we have you in our mind in working with us on COBA. We'll be coming to you. So, ladies and gentlemen, Hannah will be able to do the Q&A session after we have the 5 panelists, 5-minute interventions from them. We'll leave it to Q&A. Feel free to write your questions on the chat box. Our team is going to collate these questions, and these questions will be answered at the end by panelists before we do a wrap-up. I'd like to move to our next panelist, who is from Terumo, BCT. Dr. Nathan Mulure has an illustrious career in the healthcare sector. He is the head of government affairs and public policy at Terumo, BCT. I have been engaging with Dr. Mulure in his various capacities in the different industries, including pharma industries, that he's been at. Dr. Mulure is also the chairperson of Coalition of Blood for Africa. COBA has found a true leader and a true champion to guide its action, its activities, and its growth. And I would like to invite Dr. Mulure on stage. And first, I'd like Dr. Mulure to tell us what's really the mandate of COBA. And we talked about partnerships. Tell us a little bit about how COBA's partnership will be a model that will lead us to achieving greater heights before we jump into the aspect of malaria. Please welcome Dr. Nathan Mulure on stage.
Thank you very much, Dr. Amit. It's a great pleasure to be in this congregation. And thank you for a great organization for this meeting. So I've heard my name is Nathan Mulure. I work for Trimo. I'm also the chair of COBA and really happy to be in this space in time, and because we believe that COBA is actually an instrument that will help us secure blood in Africa. We all know that blood is quite scarce within our borders, despite the fact that we have a lot of people. If you visit public facilities, hospitals, private sector, there's paucity of blood in many, many situations. I want to change this. So COBA mandate basically will be to work with various partners, various governments, ministries of health, the population at large, to put in place a regular blood donation system that can ensure that the healthcare ecosystem is supplied adequate blood. Not only adequate, but also safe blood. In a nutshell, that is our mandate, and we want to work with all our partners to ensure that this is happening. If you look at statistics in Africa, you really find yourself in a sorry state. Blood was declared as an essential medicines product 41 years ago. Essential means that blood should be available, should be accessible, and should be affordable to the people that need it. All these qualifications of blood are not met today. We know that there are many challenges. There are challenges in the system of collection of blood. There are challenges in the infrastructure of blood in various hospitals and various ministries of health. There's challenge in blood donation. How do we then address these challenges at various levels to ensure that at the end of the day, we'll have adequate blood, we'll have safe blood in the ecosystem of our healthcare system? We want also to put blood as a key piece in health systems strengthening. We've mentioned before that without blood, no matter how good a surgery is, no matter how good a transplant is, if we don't have adequate blood, that patient could die. And all those efforts will come to naught, will come to waste. So really to work with partners to ensure that blood is available, blood is safe, and blood can be given to the patients that need blood. And to be in this space of malaria, I've been working over the last 20 years. I've seen patients who are kept in hospital, they can't be discharged because of lack of blood. This puts a very heavy economic burden on the healthcare system. If blood were available, these patients would be discharged much earlier and would go home. So let us work together as partners in this industry, partners in this blood space, to ensure that this essential medicinal product is available, is accessible, and can be given to patients when they need it. Thank you.
Thank you, Dr. Mulure. You have segued us into a very important topic still on malaria. I would really like your opinion, since you've had great examples and great experience. What is really the unique relation between malaria and sickle cell disease? One is an infectious disease, and yet one is an NCD. In this dual management, in this condition, is it something we should be discussing about? Is it something of a concern for us in Africa? Over to you.
Thank you. Again, you bring a very important topic on blood, malaria, and sickle cell disease. I tend to call them the unhappy triad. These three are linked at the hip. If you look at the history of blood and sickle cell disease and malaria in Africa, actually sickle cell disease was ravaging Africa for a very long time. So there happened to be a genetic mutation in the hemoglobin gene that tended to protect patients from getting malaria. It was a survival mechanism. So the patients who are carriers of sickle cell disease are protected from getting malaria. Unfortunately, patients who are sickle cell patients, who have the SS type, they tend to suffer severe malaria, and many of them would die before the age of 5. Our data actually tells us that up to 90% of the patients will die before the age of 5. We've got good data in a country like Uganda, and Uganda, they usually get every year about 30,000 sickle cell patients or babies who are born of sickle cell disease. And within 5 years, 27,000 of these patients are projected to die. That's 90%. And it's a very, very huge scourge on the healthcare system in countries like Uganda and also all over Africa, because sickle cell disease is the most common genetic disease in the world. And over 90% of these patients are found in Africa because of the reason that I spoke about briefly. So there's a very, very close linkage between these two. Unfortunately, those patients that have sickle cell disease also live in malaria endemic areas. And so they're exposed to malaria very many times. And unfortunately, these patients are not even diagnosed of sickle cell disease. They go to the hospital, they're treated for pneumonia, they're treated for malaria, they're treated for bacterial infection, they're treated for anemia many, many times, even over the first 2, 3, 4 years. And sometimes our doctors and healthcare workers don't have that acumen to think about sickle cell disease. So they keep on pumping these antibiotics and antimalarials to these children. And a vast majority will die without diagnosis of sickle cell disease. So we want to work with various stakeholders at many levels, starting with doctors, patient groups, caregivers, and they should have this instinct or this eye to think of malaria or to think of sickle cell disease. If you diagnose sickle cell disease early and put these patients on treatment, then they tend to live a long life. In the US, for example, patients live to 60, 70, 80 years. 95% of them attain adulthood. In Africa, 95% of them don't even go beyond childhood. This is a tragedy for Africa. And we must have a double-pronged approach. As we talk about malaria today, we must not forget to talk about sickle cell disease. It will be futile for many governments and agencies to put in so much money on malaria, bed nets, treatment, education, without touching on sickle cell disease. No wonder Dr. Amit said, today we still have about 600,000 deaths of malaria, 600,000 deaths, mostly in Africa. Could be these deaths are also linked to sickle cell disease. And without tackling sickle cell disease, we're just scratching the surface. We call upon all the partners, all the agencies, WHO, PMI, to have an eye on sickle cell disease, because without this, we shall still have a lot of deaths from sickle cell disease that are linked to malaria. Thank you.
Thank you so much for elucidating that. I used to think unhappy triad was related to the knee. Today, I've seen another unhappy triad between sickle cell, blood, and malaria. And I think you raise a very important point that we need sickle cell disease patients in Africa to live a full life. If they can live a full life in US, and there are methods available that are simple and available, why can't we give it to the 95% of the sickle cell disease patients that can't live a full life? They hardly finish childhood. Those are shocking statistics. We have work to do in our hand, and we have to work with both public, private sector, and all other partners. Thank you, Dr. Mulure. Let me bring now on stage Dr. Joseph Mulenga. Dr. Mulenga is based in Zambia. He is the medical director of the Zambia National Blood Transfusion Services. I had the pleasure of meeting Dr. Mulenga in Lusaka and saw his passion, his engagement, and he is completely committed to a model of making Africa much better when it comes to blood systems. Dr. Mulenga, it's a pleasure to have you. I really want you to start by sharing your experience about the amount of blood and components that you collect through the systems that you've set, and which disease burden actually takes up the highest supply of blood, and what does malaria take up in this space? What other conditions are challenging? And do you have more challenges right now that you are dealing with in order to save more lives? Dr. Mulenga, welcome on stage. I pass it on to you.
Thank you very much, Dr. Amit. Thank you very much, the audience. Yes, I'm Dr. Mlenga, Medical Director of National Blood Service, as Dr. Amit has said. I have 31 years of experience in managing regionally and centrally managed blood system in Zambia. Yes, the burden of malaria, as we pointed out in endemic areas such as Zambia, is very high, and the proportion of blood units that are needed for these particular patient groups with severe malaria anemia is quite high. In Zambia, what we've observed over the many years is that if you split the urban areas and the rural areas, you will see some kind of difference. In the rural areas, sometimes as much as 60% of the blood that is needed or supplied goes to support severe malaria cases. When you go into peri-urban, that figure comes to about 40%, but when it comes to urban centers or capital city in Lusaka, we do have some data that we'll try to analyze to compare, the distribution of the demand for malaria, for blood in these patient groups, and see that in the capital city, really, it's not the major indicator for blood. It is actually third in the line. So you can see in areas where there are interventions, controls, and case management, where you get prevention, detection, as well as management is improved, there is a corresponding drop in the demand for blood in these patient groups, in that you avoid severe malaria anemia, as malaria is managed properly before it gets into more complicated. So really, if you look at our network in Zambia has got 10 blood collection centers. We call them provincial blood centers, which are nationally coordinated. So each province has got a provincial blood center that has got the capability to recruit blood donors, collect blood, test the blood for infectious markers that are blood transmissible, then produce the components of blood into red cells, fresh frozen plasma, platelets, as well as cryo, and then distribute to a network of public hospitals, faith-based hospitals, military hospitals. In Zambia, we don't have a disaggregated system. Everything under the Ministry of Health, and the only institution mandated to perform and implement the blood safety strategy is the Zambia National Blood Transfusion Service. So we collect and test processed blood in the 10 centers and then distribute to all the facilities. Currently, from the 10 centers, we supply blood to 203 hospitals in the country, categorized, as I mentioned, the public, which make up the bulk of the hospital. We have private hospitals, military hospitals, and faith-based and the church. Yes, malaria is really a problem, especially when it's not managed properly. And then the demand for the product, rises correspondingly when we've missed those critical points of prevention, management, and detection. Our current challenge really is meeting the supply, because apart from that patient group, the next big challenge is postpartum hemorrhage. So that forms the second largest group of patients where the bulk of the blood goes. Again, this is pretty uniform. 20 to 30% of our blood needs actually go to the women in childbirth, with the complications, hemorrhagic complications of childbirth. APH, PPH, but mostly PPH, which is more difficult, to manage. In fact, as a young doctor, as an intern, that was my turning point, one of my turning points in my career to join the blood service, because of what I encountered earlier in my career with atonic uterus, and the complexities of managing it. Yeah, so really in Zambia, the challenge is how do we meet the national needs for the blood supply? Zambia has basically introduced more sophisticated medical procedures in the last 5-6 years. We now do open heart surgery. We do kidney transplants. We have a robust oncology management system for all the cancers. We do have a good strategy for managing sickle cells through red blood cell exchange using innovative technologies that have been introduced mostly through collaboration with Terumo, BCT. The other really big patient groups are those traumas and emergencies. But I think in terms of ranking, malaria anemia, severe malaria anemia, number one, obstetric hemorrhage, number two. These open cardiac cases, surgery, Zambia has built one of the state-of-the-art heart hospitals. They are doing very complex heart surgeries at the moment, and the amount of products that are needed to support each individual case of, an open heart surgery is quite enormous. So you've seen a shift, in the demand for blood to more specialized services that are using more blood per patient per capita than those basic medical services that we're dealing with 5 years earlier. So the demand really has shifted from the WHO prescribed 1% of the population if you are engaged in basic medical services, meaning you are treating malaria for anemia where you just maybe 2 units. The patient, if in pediatrics, maybe you just need half a unit. You need maybe 100 mils, 200 mils, per patient. Basic surgical support. But now when you start doing managing open heart surgery, managing oncology, managing sickle cell, through red blood cell exchange, the demand per patient is so high. So once you start that, what we've done in Zambia is just to calculate and migrate to 2% of their population. So Zambia's population is 20 million at the moment, going to 21. So the target would have been 200,000 if we're doing just basic medical services. We had been grappling, but slowly getting towards that target over the years. 5 years ago, I think we went as far as 130,000 units towards meeting that goal. But things changed when these specialized services were introduced, such that now we have changed our goal to 2% of the 20 million population. So our current target of annual blood collection is 400,000 units of blood. Where are we? On that, the gap is up to 2023, where we collected 130,000 units. So you can imagine the gap. So for 2024, we intend to collect 260,000 units of blood, which is almost double what we collected last year. That's a strategy we're embarking on this year. And by 2026, we hope to meet that target of 400,000 units of blood. There's some significant investment that has been put in the blood service in Zambia. In Zambia, blood transfusion is taken as a presidential priority. In fact, it's been pronounced by the president that he's got 2 priorities in quality health care. One is reduction in maternal mortality. 2, it's the support to the blood service as a means to reduce maternal mortality. So we have the attention of the Republican president, who is committed to ensuring that Zambia meets its goal of ensuring a sustainable, safe, and adequate blood system, by 2026, by making sure that we've reached our target of 400,000 units. What is our strategy for donor mobilization? What we've set out this year is to craft a strategy, a communication strategy that we hope will reach 250,000 people in terms of messaging, using all different platforms to reach the entire Zambian population. If we can get the messages across to 250,000 people, we intend to retain 200,000 of those 250,000. And if we can convince them to donate twice per annum in the period that follows between now and 2026, then we can reach our goal of getting our 400,000 target. So what is the investment we are working on? Firstly, is strengthening and making sure looking for appropriate partners for the donor mobilization campaign to get these 250,000 people with messages that appeal to them, appeal to their conscience, proper package that they are aware. Because one of the problems I think over the years that we realize is that whereas people might be willing to donate blood, some people sometimes just say, I've never been asked. You never told me. I don't know. I've never been asked. And if you ask yourself, it's true, because as we know, blood is a non-for-profit making activity. It is not underpinned by vigorous commercial marketing sales strategies as would big corporates, that are profit making. Just by its very nature, that the blood and products that we produce are a public good which should be given to all without discrimination, irrespective of their status in society, whether they are poor, whether they're young, old, whether they are black, yellow, it should be reached by all who deserve, because it's a life-saving intervention. As we know, blood is a supportive therapy. It contributes, in our understanding, to the restoration of health. That's what blood does. But the problem is, if it is not given timely when it is needed, the outcomes are fatal, death occurs. And that's what makes it very, very sensitive. But also its source are human beings. I mean, science up to now has eluded us. We do not have a clear substitute for blood. So if you bring in all those challenges, really, it's very important that there is participation, firstly by government. I think government is number one. That's how we take it in Zambia. Why? Because it's a security issue. A country that it does not a safe and adequate blood supply, it's insecure. We don't want to anticipate that the war will break out or calamities will happen, earthquakes and all that. But if a country is not sufficient, not self-sufficient, it's really very, very difficult to say you are safe as a country from a security perspective. And who is responsible for ensuring the security of a country? It's a government. So a government should take center stage, in our view. That is exactly how we view it in Zambia. And that is why, we've always emphasized that the blood services are under the supervision and direct control of the Ministry of Health.
Super. Thank you, Dr. Mulenga, for that comprehensive experience share. What I heard you say is you have a target of 400,000 units by 2026. You are at 130,000 at the moment, and
Yes.
slowly you're going to reach towards that through many initiatives. And I think country by country, region by region, around the continent, we need to start thinking about blood donation seriously, because many people are saying they've never been asked. And other people say that they don't know where and they don't know how. So the initiative that we need to start taking is we can triple the donations in Africa by a very clever comms strategy and a structure strategy. And if we do this jointly, and we said that every third Saturday of every month in different parts of Africa, the schools are out and we use the infrastructure, and you have a set Africa blood drive system. We talked about this. So maybe it could be something you can talk to your comms people, the people in this space, but we do need to collect more. If we collect more, we'll be able to save more. But I really like what you also said, that early detection, management, and prevention is going to reduce the burden of blood required even for malaria. And there is a difference between what we saw in the rural areas and in the urban areas. So this is a great mix that we are seeing that is coming through. I would really, really like that. I do have a doctor who is from the rural area, following you, Dr. Mulenga. Dr. Millicent Wanyama actually is a pediatrician, and she's treating so many babies and children. And she's daily faced with challenges of treating severe malaria mixed with blood shortages, and how difficult it can sometimes be on who to test, who not to test. I'd like to invite Dr. Millicent Wanyama on stage to give us her experience sharing. She's a pediatrician and a sickle cell program lead at Webuye County Hospital in Kenya. So let's welcome Dr. Millicent on stage and share her experience about this mix that you've been having of treating patients. Millicent, the stage is yours.
Thank you so much, Dr. Amit. Thank you so much to the audience. As you've heard, my name is Dr. Millicent Wanyama. I'm a consultant pediatrician and also the sickle cell program lead at Webuye County Hospital. And Webuye County Hospital is a level 4 government facility in the rural Western Kenya, where sickle cell disease and malaria is quite endemic. And also it's a region that borders the eastern part of Uganda. So in my experience, managing patients with malaria, I'd say, as I've alluded before, Western Kenya is endemic for sickle cell disease, and there is no single day that passes without my team and I encountering a child with malaria, either uncomplicated malaria, where we treat them as outpatient, or severe malaria that requires them to be admitted in the hospital. For the patients with severe malaria, I'd say 80% of these patients would present with severe anemia. And this is further worsened by the endemicity of sickle cell disease in the region. So you'd find that most of my patients, when they get the sickle cell patients, when they get malaria, is quite severe, and they usually present with anemia. So unfortunately, blood is a problem. It's while it's like a problem in the country and also in my facility. So most of our patients would lack blood. Sometimes we'll call in the regional blood banks or even the satellite blood banks around, and we are told there is no blood. And so I guess in point, you have a child with sickle cell disease, severe anemia that requires transfusion, but unfortunately there is no blood. So most of the time, we lose patients because of this. And in some circumstances, healthcare workers have actually had to donate blood to save patients' lives. So the situation is quite dire in my region.
Wow, wow. We can just imagine how the situation is, and you can see also what Dr. Mulenga mentioned, that the highest demand is there, and health workers need to donate blood to save a child's life. I'm sure many of us who are health workers here understand what we have been through. I remember also purchasing granulas to deliver IV quinine those days, besides even delivering and having blood. What is your view about, are we doing better in testing for malaria in good time, or are we still struggling testing malaria properly and in appropriate ways, and people are self-diagnosing and probably self-treating? Is the situation in Webuye, in the places where is it getting worse or is it getting better?
Okay, thank you. So I'd say testing for malaria has really improved over time. I practice as an intern in Webuye County Hospital. So about 10 years ago, so if I compared testing 10 years ago and now, I'd say that testing has really improved. We are doing a lot of testing for malaria before starting patients on antimalarials. And what has led to this improved testing, I'd say one is the use of CHVs. CHVs, the community health volunteers have been trained on educating community members on malaria, and also they have been trained on use of RDTs. So they're actually educating the community members as well as testing in the communities, and where possible, refer patients to the healthcare facilities. Another thing is that nowadays, before any government facility dispenses off medication, so before any pharmacist dispense of medication, patients must have proof that they have malaria. So either a positive RDT or a positive blood slide. So without that, then they cannot dispense medications. So I'd say this has really helped in terms of testing for malaria. And also, in a way, it has helped us to now rule out other febrile illnesses, because initially we could just, any child or any person presenting with fever, headache, malaise, we assume it's malaria because it's in a malaria endemic region. But now, because of the improved testing, we are actually able to rule out other causes of febrile illness, which is a good thing.
Thank you. I think you've touched, and it's good. It's a sigh of relief for many of us.
Yeah.
You know, comparing 10 years ago, where we were and where we are, but still there's a lot to do. And that's why I want to bring in Dr. Angela Harrison, who is from South Africa, but currently dialing in from Kigali. And Angela is from Sysmex. So Angela, I really want to bring you up on stage. And I know that Sysmex have been on the cutting edge on diagnostics for malaria. You've been looking at different models in how to improve accessibility. As we know, access to tests is important. But in Africa, affordability also has a big interplay in access. What are the new diagnostics for malaria? How easy and affordable are we going to get? What do we expect to see? And well done with all the great work Sysmex is doing in bringing cutting-edge technology in Southern and East Africa, which is your region of focus. So please welcome to stage the Scientific and Medical Affairs Manager from Sysmex, Dr. Angela Harrison.
Thank you very much, Dr. Amit. So I think, as Dr. Millicent was saying, you know, in the last 10 years, we've come a long way as far as testing is concerned. And every testing platform has got a very important place. You know, RDTs have got a very important place in being able to be used in very rural settings where there is energy issues, there's, you know, very resource constrained settings. And microscopy has been your golden standard and still is the golden standard for most of malaria testing. We as Sysmex, we have obviously been having a look at, we value a patient holistically, and obviously we are very strong in hematology. And so the current trend, or where we've taken things and we've kind of spearheaded it as much as we can, is diagnostics with a hematology device to be able to diagnose malaria. So we do have an analyzer that will give you a complete blood count at the same time as giving you a parasitemia level for malaria-infected red blood cells. So the importance for us when we're talking about having your CBC present at the same time as being able to get a malaria positive or negative is you're able to have those red blood cells indices. So you can see the anemia potential of the patient, but also platelets with thrombocytopenia that's very common with malaria. And having that availability, you're able to get treatment to the patient as soon as possible hopefully without getting to the point where they require blood transfusion, because as we know, blood supply is it's not where it needs to be in the continent. And unfortunately, as far as donations are concerned, and it's quite a controversial topic, which I'm sure we might be able to address later, identifying malaria in blood bags and what do you do with it? We don't really have enough blood supply in Africa to be able to just discard blood on the basis of it being malaria positive. But at the same time, we need to be responsible in knowing that AMR is a problem and getting resistance towards the current anti-malarial drugs is an issue. So prophylactically treating, you know, there's different countries have got different ways of doing it. So if they have screened for malaria in the blood bags, but they need to triage that blood, it becomes quite an important thing to know whether or not you need to treat a patient with malaria drugs prior to them having a transfusion. And we need to be able to find a fine balance between knowing that the blood has got malaria in it and prophylactically treating, and not just prophylactically treating everyone. So luckily, our analyzer is extremely sensitive. It's not as sensitive as PCR, but I mean, we look at PCR, it's a very expensive way of testing, and yes, without fail, it's going to be your most sensitive. But our analyzer comes in just below that as far as detection limit is concerned. And something that we're very passionate about, obviously, is maternal health care and babies or children under 5. We've had quite a few studies where we are starting to see extreme parasitemia levels in children under 5, but they're completely asymptomatic. This was something we saw in Homa Bay in Kenya, where we were running blood samples. The children were completely asymptomatic, but their parasitemia levels were insane. And unfortunately, those were the children that were going to require blood transfusions because of the level of parasitemia. So our aim is to be able to detect malaria as soon as possible in very low concentrations, so that we can preempt and start treating the patient before it gets to the point of actually requiring a blood transfusion. And that's where we're going at the moment. And obviously, we're increasing our capabilities, and we're doing as much as we can to make it available, even in the smaller rural settings.
Excellent. You know, you touched on some very important parts. You talked about under 5, this amazing Homa Bay study and maternal health, but you also talked about the gold standard being microscopy. And what is the role of AI in malaria? Is this something that we are going to enter into quite easily? And how much of it are we already doing?
So I think there's a lot of people right now. Obviously, AI is something that's coming, and especially in some of the more Western areas, there's a lot of research that's being done on it, training automated microscopes to be able to identify different parasites that are born within the blood, different oncologies, even finding sickle cell patients, you name it, that they're starting to do it. And AI is definitely something that most companies are looking into to be able to do it. There's a little bit of back and forth as far as FDA clearance is concerned when we're talking about AI and computer learning for microscopy. I think it's definitely coming, but how soon is another question. I have seen some situations where we are starting to see analyzers that are able to do it on the digital microscopy. Again, this becomes a bit of an expensive sort of method, because you do require the digital microscopes to be able to do that. So it becomes quite expensive in that sense. Luckily for us, our technology is not that expensive when it comes to costs per test for the individuals. But I think AI is coming, and I think it's something that all companies, doctors, hospitals, clinicians, they need to be aware of the fact that it is coming, and one day we will get there. How soon? I can't say, and hopefully the African continent will be up to date and keeping up to date with what's happening in the Western world. I think that sometimes we're a neglected continent, and it is our responsibility to make sure that we are still getting the cutting edge technologies as they come into the countries.
I agree with you. It's coming, it's unstoppable. Let's hope in our lifetime we'll see more AIs helping more people, saving more lives, and making people live longer. We just need to get data, and we start getting these digital microscope films, data. And I think the more we feed into the system, the greater the generation will be living. Thank you so much, Angela, for dialing in. I think it brings us very nicely to yet another partner of ours, Roche, who has been front and central of discussing the coalition of Blood for Africa. Your involvement and your partnership is absolutely appreciated. Not only what you do in blood, but what you do globally as Roche. And a little bit more discussion today will be around diagnostics. Dr. Harry Mapesi, who is the medical lead for Pan-Africa Infectious Disease from Roche Diagnostics, is with us. I think Harry might be dialing in from Uganda, but he'll tell us where he's dialing in from. Or Tanzania, I hear, is his home country. But I would like to invite Harry on stage. And Harry, let me begin the floor discussion that your website says an undiagnosed infection is an untreated one. It couldn't be further from the truth on the topic we're discussing today. I really want to talk to you about the point of care testing. POCs have become central, front and central discussions. We saw it during the pandemic. We've seen it during outbreaks. Every facility in Africa is now not looking for big, shiny machines that will take 48 tests or 96 tests or 100 tests, but they want to take nimble, agile tests to save lives. Point of care connected diagnostics are becoming central. Speak to us about Roche and where you see these tests are moving. And you keep talking about the 10 by 10 matrix. I really like that. You want to get more diagnostic done. You guys have been talking about multiplying the 10 by 10 matrix. Talk to us a little bit about that. Ladies and gentlemen, please welcome Harry Mapesi on stage.
Thank you very much, Dr. Amit, for your kind introduction. So I'm dialing from Nairobi, actually, although originally I'm Tanzanian. So first, you raised a very good point about undiagnosed disease is untreated one. And I take you back 3 years where the Lancet Commission of Diagnosis was first published. And the authors showed that more than 80% of people living in low and middle income countries, they don't have access to basic diagnostics. And when you read the report in detail, the author approximated more than 1.1 million deaths would have been averted if these people they had access to these basic diagnostics. So for us, that this is kind of information that is mind-blowing. And then you have more than 60 and 70% of decisions that we make as clinicians, really their bed is in diagnostics. So this is really, really key for us. And that's one of the mission for us as a company. How do we increase access to diagnostics across the continent in Africa? Now, you raised another point. You mentioned a very good point about 10 times, tenfold. So last year, I take you back again last year when at the World Health Assembly, where diagnostic resolution was signed, for us was a very big achievement. Ideally, the global stage now recognize the role of diagnostics in the treatment of patients and what does it mean to the whole healthcare system. So for us at Roche Diagnostics, one of our vision or our ambition is really to increase to increase test or access to patients tenfold by 2030. And the idea is how do we fill the gap that I mentioned from the Lancet? Like if more than 80% don't have access, how do we do that, right? And as you mentioned, one of the ways, of course, is using high throughput and medium throughput platforms. I can go into details later, but point of care is one of the key that also as a company we see is really, really crucial. And ideally, if let's say I'm from Tanzania and I used to work in the rural Tanzania, where sometimes you don't have electricity for 3 days or it's too hot. And sometimes you have these instruments and they come there and they won't work because of the temperature condition or the humid, you know. So for us, one of the vision is as a company is how do we bring this near to patient or point of care testing, new and innovative tests which are more robust to this peripheral area, really to increase access to this kind of diagnostics, specifically molecular diagnostics in the rural area. Although in some other disease, we already have those kind of solutions that we have, but one of the place that now we are focusing as well is really how do we bring this kind of molecular testing in the rural, low and middle income countries, basically.
No, I think you touched really about the volume of testing, the quality of testing. You also talked about infrastructure challenges in some of these situations in rural setup. You also, are involved across in many ways in the diagnostic space. Let's circle back to malaria and blood. In your opinion, is blood and blood products on our continent, by the time we collect it, is it safe? One of the fear that patients have surgery or in emergency is not just having blood, but having safe blood. And to have safe blood, we need to make sure the right kind of tests are done. All the kind of tests are done. And you really don't want to have diseases or conditions which you have avoided if you didn't have to take blood. But on the other hand, you needed blood to save your life. So can you talk to us about safety on our continent and what we should be focusing on?
Thank you very much. Ahmed, that's a very long question. So, I mean, it's a very broad topic, right? And one of the things that we see, I mean, I'm a physician, right? So I really want my patient to receive the safest blood they can get. And one of the things that as a company that we are focusing on is really how do we bring safe blood solutions to the laboratories, and how do we work with policymakers and decision makers to establish the blood banks that produce as safety blood as possible with new and innovative technology. And
Yeah.
I give you an example. I was just recently in Uganda. And ideally, we've been working there with Uganda Blood Transfusion Services, really. And this is not only in Uganda, because we have other countries that you're working on. And the idea is quite complicated because you have serology testing, you have NAT testing. So some countries will come and okay, how do we work together to see how they can complement each other? For example, these tests, which are more sensitive, right? So how do we make sure that as a private, and we work with the public sector and really look at, okay, in your algorithm, what would make sense? How do we make blood as safe as possible for the recipients?
Yeah. You know, it's also on the chat. Somebody has asked Shia on how can technology be used. And, you know, as we move to the Q&A, which I will ask the panelists to answer just in a few minutes, we take the test to the blood. Is there a possibility to take blood to the test? So rather than testing different things on blood, what if there was technology or some equipment where you could put the drops of blood and it picks all the sensitive pathogens or abnormalities and it gives you a report that did you know that the following. So I'm just trying to think of multiple tests through a system that gives it a minimal viable product. You need to reach the MVP before the blood is transfused in a quick way. So this is just wishful thinking that I'm putting up to you, Harry. Do you have a comment on it? Or before I feel the questions that I've said?
No, I think you said it pretty well. And I think, yeah, even for us, I mean, that's like you said, it's an MVP, and that's what something also we wish, and hopefully we will succeed soon.
Looking forward to that. I would like to invite all the panelists back on stage. If you can put on your cameras and come over. There's some very interesting questions which I want to distribute and see your responses or suggestions and discussions. Let me start with Hannah. Are you with us, Hannah? If you're with us, it's probably not directly related to CDC, and you can respond. But one question, Hannah, is the Molly Sobola is worried about brain drain. Can you keep African doctors in Africa so that they don't run away to earn dollars and pounds and other currencies? Is CDC trying to keep our health workers in Africa? Can you speak to that?
Yes, thank you, Dr. Amit. I think that is a very important question that is often raised, as it is a very, it's a key challenge in the continent. And what I would say to this question is some of the strategies Africa CDC is implementing to tackle this issue is to enhance training and educational opportunities for healthcare professionals within our continent, within our African countries. And by creating mentorship programs, professional support networks, such as the Kofi Annan Fellowship, for example, so that we enhance the career growth and we enhance the satisfaction of the healthcare professionals. That way, healthcare workers are able to find the quality opportunities within their home countries. Yeah, I think I'll concede there.
Thank you. Dr. Mulenga, there are two questions. One is from Nelson Washira, and another one is from Beatrice Lungai. Nelson's asking safe blood transfusions for malaria in remote areas. Are there some interesting and innovations to enhance access and availability? And the second question might be related from Beatrice, decentralizing blood screening might reduce errors and turnaround time. You mentioned 10 centers that you have. How much decentralization are you practicing in Zambia for this? Over to you.
Thank you so much, and thank you, Nelson and Beatrice, for those questions. So the first question is based on the accessibility and availability of blood in the remote areas. The way we've set up in Zambia is that we have the 10 centers, as rightly observed, which does the collection, testing, processing. We call them manufacturing, production, storage, and distribution centers. That's what we call them. Because that's where we do all the manufacturing and processing and testing. And then, we devolve this to the hospitals where blood is stored for patient access, where the hospital blood banks are and cross-match labs are. So on one hand, it's a question of availability, meaning the numbers. Do we have sufficient quantity? Okay, we're saying that at the moment we're striving, but we have a shortfall. And that's why we're trying to bridge the gap through these different strategies, through the comms strategy and the raising awareness and the education campaigns across the country, so that we bridge the gap. The second is, collapsing the distances between the hospitals where these services are required and the production centers, the 10 centers. So in Zambia, what we proposed, Zambia is a vast country in terms of size. It's 752,000 square kilometers. So you can imagine, the long distances between facilities. So what we've proposed in Zambia is to build hubs in each province, what we are calling storage and distribution hubs. It must be very clearly understood that there's no testing that takes place in those hubs. It's just storage and distribution. The testing takes place in those 10 regional centers. That is where all the testing takes place. So once blood is now tested and it's safe, it is debulked to the hubs. And what we've done in Zambia is to identify 2 hubs per province, such that in the end, we will have 3 access points in the province for blood products. 2 hubs plus a very facility where the production takes place, because it also does the storage and distribution. So currently, if we look at the current scenario, we have 10 point distribution. That will be increased to 30 once the 20 hubs, 2 per province, are added to the current 10 distribution centers. And that has been funded, and they were just in the process of finalizing procurement of this infrastructure so that we collapse the distances. So that is how we try to make blood available equitably, because the Zambian medical vision is equity of access to quality health care as close to the family as possible. That is a vision of the Ministry of Health. So we try to follow that vision so that we also make sure the blood products are available as close to the family. But in this case, the lowest level is what we call level 1 hospital. That's where blood transfusion takes place, where there's a physician, there's a laboratory, and the requisite infrastructure to perform a safe blood transfusion. And then we go to level 2, level 3, and tertiary facilities. We do not go below level 1 hospital, which are district hospitals, because below that, we don't have doctors, we don't have labs, I don't have the infrastructure and the technology and know-how to perform a safe blood transfusion. So for us, all patients who require transfusion, they have to be managed at the lowest level as a level 1 hospital, which is a district hospital. So patients need to be brought to that level, and our goal is to make sure that we get the safe blood products to those facilities. The next question is about testing. Yes, we test in the 10 centers. Currently, we're using the Abbott Alinity, which is standardized across all the 10 centers. Of course, in future, we might go on that. But again, the model with NAT that we did some years back with Roche and did some modeling, that might collapse those 10 centers of testing to only 3 if we use the NAT testing model. We did the modeling with Roche using their consultants. We looked at Zambia specifically. So in future, when we go full NAT, we might collapse the 10 centers to 3. It might even be less. But that's the time when our target was 200,000. I don't know what the scenario will look like now that we are focusing on 400,000 donation per annum. Yes, so really, it is important that testing is standardized, because once you have multiple testing sites, one, you limit yourself in terms of the technology that can be applied, because most of the blood bank technology as an industry require the more sophisticated the technology, the higher the throughput. Alinity now does over 300 tests in a run. It was an improvement from the Architect, that the predecessor to the Alinity. The Architect was doing about 60 tests per run, now at 5 times more. That way, you know, our capability to process and, you know, through this more enhanced capabilities, you know, is much more. And we're going into full blood automation using the Revios, which we are rolling out throughout the country so that we can start producing, you know, blood components and make 100% component production. That's our goal for Zambia. And again, you know, you cannot deploy the Revios beyond the major production facilities. So our goal is to make sure that it reaches all 10 centers to produce the various blood products, the red cells, the platelets, and the fresh frozen plasma and cryo. Leukodepleted products, especially if you are using the Revios, which is quite robust, and its throughput is very, very. In fact, one piece of the Revios machine per annum, if you are using shifts, you can process over 100,000 units just on one machine. Imagine 4 machines probably can process the whole 400,000. But in Zambia, we have 2. So in the next 2-3 weeks, we're deploying 4 more Revios. They are on the way. That way, we can distribute the components, you know, to reach out to the entire country. So manufacturing and distribution should be separated in our, I mean, manufacturing should do, actually, if you're going to talk about quality, you know, should be more or less centralized as much as possible, as reasonably as possible, depending on the country specifics, you know, but what should be decentralized is the distribution and accessibility, then the infrastructure that is required to actually make this product reach, you know, areas that are needed, where the district hospitals are in the rural areas.
Correct. No, this is really good. So, Hannah, when we do the Africa Blood Forum discussion at the end of the year in Rabat at CPHIA, we should invite Dr. Joseph Mulenga, almost like a case study of Zambia. And when Dr. Mulenga speaks, it's almost sounding like a case study where other countries should multiply, replicate, and do things in blood. So Dr. Mulenga, don't miss coming to Morocco. At the end of the year, we might have the Africa Blood Forum, and you should speak to the other ministries of health and inspire them. So watch out for the invite.
Send me the invitation in time so that I get a visa in time.
Yes.
Traveling in Africa is a nightmare.
Yes, we will make sure we will work on that. I want to move now into a little bit of a tricky situation. Nelson Washira and Peter Kamisi have raised interesting. You know, Nelson's talking about misconceptions, stigma, beliefs, socio-cultural barriers. And I want to bring Nathan onto the stage because Peter Kamisi has also said directly to you and the Minister of Health and anyone who can respond. They're saying Kenya is insecure. Public has always come in when there is a call to donate. In fact, many of us get calls. Please send in blood. Please send relatives. He's talking that donations have been known to enrich some unscrupulous players and officials at the blood bank. Wow. And have made it a business selling this commodity. And so has made the public stay away from donating. What measures are being put in place? Is it a big issue about corruption? Is there a big issue about some people having socio-cultural barriers in donating blood? And is it a big issue about stigma? Nathan, what's your view about this?
Well, thank you. That's a bombshell question. And I'll try to address it as much as I can. But before I address that question, I think we need to look at the whole ecosystem of blood, not in a point manner, but in a linear manner. It's actually the blood journey. Blood, right from the time it's donated to the time it's transfused, that quality assurance needs to be put in place. So there's need, of course, for a lot of education on the blood donors. They are a rich resource for blood. They need to be appreciated. And also they need to be educated about blood. There's so much misconception about blood as we speak today. So many myths about blood. And these myths keep people away from donating blood. So I think if we have a very good strategy, and as COBA, we need to really look at the grassroots approach on how to educate the public on blood donation, the benefits of blood donation, the reasons that one can give blood, the reasons that one can be refused to give blood. All these need to be put in black and white to the donors. We also need to think about another what Zambia has done. Actually, automation is a very good path to take in terms of ensuring that blood is adequate and blood is of good quality. So the catchment that you are going to get your blood donors from actually determines the kind of blood you're going to, quality you're going to get. Usually we say voluntary blood donors that are not paid amongst the best and the safest donors. The ones that are paid or coming from family who are coerced because it's a close patient who is in need of blood, they tend to have less safe blood, especially from those that are paid in countries where it's paid. So we need to really encourage people to become voluntary blood donors to enrich that pool of donors that will be able to give blood. Testing also is very, very important. I know many centers are doing the 4 tests, the 4 TTIs. And unfortunately, some countries don't even have the equipment. So I've heard of countries where they're doing rapid diagnostic tests before they give blood transfusion, and that is not the best test to do. So we need to really have the immunoassay testing and even NAT testing for those that can afford to help us bring quality blood to the populations. Also, for us to ensure blood is adequate, we need now to stop thinking about whole blood donation and think about components. If a patient needs platelets, let them have platelets. If a patient needs plasma, let them have plasma. If they need white blood cells or RBCs, then that, I think, would really help in terms of increasing access to blood and blood products. We know that donors who want to give plasma, for example, can actually do it 2 or 3 times a week. So they can give the plasma more regularly. Some just can also give RBCs. So instead of getting the whole blood, use machines that can actually extract the RBCs, red blood cell exchange. So these need to be put in place to ensure that there's automation, there is increase in terms of quality blood, and that can help reduce the discard rate. Again, if you have a lot of blood that is not well processed, there's contamination, it ends up being destroyed, and that affects the environment. To destroy plasma or to destroy red blood cells that have been collected from a patient into the environment, again, is another whole game plan that affects ESG. So allow us to look at blood, not as a pinpoint, but really the whole blood journey from the community to the testing site, to the donation, to the transfusion. All that is one continuum that will not be looked at from different angles, but as a whole, belt of our supply chain for the blood. So that is quite important for us to think of it in that holistic manner. In terms of corruption in the blood segment, again, it's a difficult question. We've read about this in the press. I have not come across a typical case, apart from what I've read in the press in the past. But I tend to think that if we can increase the level of education for the blood donors, for the community, we're going to reduce some of these myths that are so much preventing people from donating blood. So we need good information sources, maybe a website from the Blood Donor Service, Ministry of Health, to really educate the public about blood donation. And that would kill a lot of myths that stop people from donating blood in our ecosystem. Thank you.
Thank you. Thank you. I think generally communication, awareness, and education is becoming such a central theme. So Africa CDC is also doing a lot in that area. Maybe, you know, when we talked about condoms many years ago, they had similar myths, issues. We're still not over it. We talk about vaccines. We've just been through misinformation and disinformation. So I think as a health industry, all of us, we have a big task in educating the population about the misinformation that is affecting strengthening of the health systems. I do want to thank you, Nathan, for bringing in this holistic approach idea. I also want to extend my thanks to some clever attendees that we have today. Gertrude Kitetu, who has told me that syndromic testing is what I was referring to when I was talking about tests going into some equipment. She calls this the panels. So I've been actually educated. Thank you, Gertrude, for that education. I do want to, after I go through the two other questions for the panelists, or three, Nelson Washira has some very interesting points. I would like Bildad Omondi to try and prepare Nelson to unmute. We'd like to hear a few words from Nelson Washira. You're very active in this space. Let me bring in Millicent. There's a lot of questions. I got 2-3 questions on prophylaxis here. Selina from Sickle Cell Foundation is asking, how can we avail malaria prophylaxis drug to sicklers? But by the way, they've been out of stock for the last 2 years. So what do you think about that, Millicent? And also related to that question is we've received another one of the same type, that a lot of discussions of prophylaxis are being put in place. What is the use of prophylaxis medication? And can you give us your views about that, Millicent? Over to you.
Thank you so much, Dr. Amit. So I agree with Selina. We've had drug stockouts of especially anti-malarials, to be specific, the proguanil or paludrin is what we use for malaria prophylaxis for sickle cell patients. And since the pandemic, the COVID pandemic hit, we've not been able to have a good supply of this medication. So what I usually tell my patients to do is there are other ways that we can do prophylaxis. We can do malaria prophylaxis. One of it is the malaria vaccine. Number 2, vector control. So ensuring that the children sleep under insecticide-treated mosquito nets, you know, cutting of the grass and the draining of water around the houses, to just ensure that we don't, children don't get malaria. But I agree there is a challenge, or there is need for malaria prophylaxis.
Yeah. Dr. Ojiambo and Carmen are also saying that we need to have a discussion for transfusions for first-line management of sickle cell warriors while speaking about prophylaxis. So I just want to thank, that's a comment from them. And Millicent, thanks for sharing light. Let me bring in Harry Mapesi about what Nelson's asking. What are the limitations of the current blood-based diagnostic methods for malaria? And are these limitations of diagnostic methods affecting accuracy of and the timeliness of diagnosis, particularly in remote areas where they have limited access to lab facility. Harry, over to you.
Yeah, thank you, Dr. Amit. I think probably Angela will be the best one because they've been developing this test for a while. But I think just on the nutshell, I think one of the challenge that I usually see is because the antigen, for example, the rapid antigen test, right? And then some of the antigen that can remain in your system even 2 weeks after treatment. So this can bring false positive results. I think that's one of the main challenge. But I would let Dr. Angela probably to continue the discussion.
Very appropriately segue to you, Angela.
Yeah, so I think diagnostically, in the resource constraint settings, RDTs is currently the best option that we have, right? But unfortunately, various genetic mutations like the HRP means that maybe we're missing malaria infections. We've got situations where a lot of the malaria tests are based for falciparum infections only, and they're not the pan-specific ones. So Sysmex at least, and I think a lot of other diagnostic companies are trying their best to be able to reduce the size of equipment, to make it equipment that will be able to detect at really low levels, not just high parasitemia levels, because that's another problem that we do face when it comes to RDTs, and making it affordable. Not making it so that it's really expensive, and the people like WHO and the Bill and Melinda Gates Foundation, where all of the funding comes from as far as malaria testing is concerned, that it is something that is affordable for everybody. So I think right now, the current solution for those rural areas where they don't have high throughput settings and you need to be able to treat patients, I think at the moment RDTs is still going to be your main point of testing. But as we are progressing, as many companies are trying to make smaller equipment, I know Sysmex, we are trying to reduce the size of our equipment to be able to get it into those resource constraint settings where you don't have access to a lot of facilities. I hope that sort of answered that question.
Right, it did. And thank you for joining in answering. But while I have you on stage, Dr. Martha is asking just contamination and the situation of contaminated blood. She's really worried about HIV, hepatitis B, 2 of those things she mentions. And the more remote the facility, the more chances you have of getting contaminated blood transfused into you. Can you comment on that?
So from the HIV and the hepatitis situation is concerned, here is probably the better one to be answering this one. From the malaria aspect, we've actually, as far as blood transfusion is concerned, we've done a study in Malawi blood bank, just to be able to compare our analyzer in the blood banks to be able to detect malaria-infected blood bags against what they currently use, which is microscopy. And as far as the amount, we had screened about 5,000 blood bags, and the analyzer that we have was able to pick up approximately an extra 600 blood bags that were malaria infected. It was checked with expert microscopy and PCR if we needed to adjudicate again. So an extra 600 blood bags were actually used for transfusion that were considered to be malaria-free. And this is where the whole conversation comes in about a lot of facilities, a lot of blood banks, they don't want to know whether or not the blood is malaria positive because it becomes an ethics problem as far as transfusing that blood or discarding the blood. Right. And from our perspective anyway, or for the ideal search of circumstance that we're looking at, we want to be able to say, it's better for you to know that the blood bag has got malaria in it, and then you can triage that blood, right? So we're not saying to discard it because we don't have the blood supply to just completely discard, but you would then be able to say, we are going to give you a malaria-infected blood bag, but we're going to prophylactically treat you, but not to prophylactically treat everybody that is receiving a blood transfusion, because then you're going to start getting antiparasitic resistance. which we also are having a problem with. And, you know, as has been raised already, there is some prophylactic treatments that have been out of stock for quite some time. And on that note, I need to go downstairs because that specific medication, there happens to be a pharmaceutical company that is specifically promoting that medication at the moment downstairs. And it would be interesting for me to be able to go and talk to them and to see what the supply issue is at the moment. Why is that drug not getting to the regions that need it for sickle cell patients for prophylactic treatment? But I think from my view, we need to know that blood bags have got malaria in it and then work around the situation instead of turning a blind eye to it and transfusing malaria-infected blood without having, you know, the right circumstances in place for best patient treatment.
Super. Harry, do you want to talk about HIV, hepatitis a bit before we go to Hannah, and then I'll call Nelson on stage?
Yeah, I think that's a very good point, especially if you're in the rural area. I've been in a situation previously, a couple of years back, where it's an emergency and then the blood will be tested with rapid test. I mean, really, it's 21st century, but it's still shocking. And if you were Dr. Amit, or anyone in this panel, if somebody is telling you that, you'll be shocked, right? But those kind of situations still exist actually now. And that's the reason why I think for me, one of the ways is how do like a private sector and public sector work together really to make sure that we get as safe blood as possible. You know, because we have the tools that they can high sensitivity within the low window period. So we have the tools, but how do we make them accessible and affordable, basically, right? So work together. I give an example. Previously, we established Global Access Program where we wanted to increase access to HIV viral load testing across low and middle income countries. Now it's in 82 countries, and even in Africa, more than 60% of viral load are done within the brush. And what we are doing is working with the governments. How do we leverage these platforms to test TB, to test hepatitis, to test HPV DNA testing? So the idea is, how do we increase this accessible? How do we make sure all these tests are really accessible to these patients?
Thanks for those very clear and elaborate explanations on the testing side. I want to bring in Hannah. There's Dr. Alama from Mauritania who's dialed in. She's saying donation is not a problem. She's actually got a network of blood collection donor ambassadors. And talk about ambassadors, Hannah, you know, some countries are now appointing blood ambassadors. So Caroline Wangamati, who is the COBA lead, who is with us today, has been appointed by the Minister of Health in Kenya as a blood ambassador. Now, imagine if we had 54 blood ambassadors across, or whatever, 100 and something. Maybe they could be our champions. We might need to have an official blood ambassador model in every country to be put. What Dr. Alama is asking is, or a comment is, really we need storage capacity in countries like Mauritania, and it might be that different countries need different aspects. But just the blood bank situation and storage is something, if you could, you know, think about and comment, Hannah, from the Africa CDC perspective. What do you think?
Thank you, Dr. Amit. I think that's a very important comment and suggestion, especially when it comes to bringing champions from different countries, because I think at the end of the day, trying to raise awareness, and the best way to do that is by allowing member states to have their own champions and yeah. And I think with regards to the support that was requested, yeah, Africa CDC is ready and committed to supporting its member states with those kind of requests.
Thank you. Before I call Nelson, let me just ask Dr. Nathan, Daniel Sikuku is saying, is there any connection between malaria and sickle cell disease? And does it need to be combined therapy to be, need combined therapy to be cured? Does it need combined? Just simply give him a short answer to that.
Yeah, so yes, there's a big connection between malaria and sickle cell disease. Historically, genetically, malaria patients survive the sickle cell disease through a genetic mutation. So the mutation of sickle cell disease, so carriers basically of sickle cell disease, those who are carriers are protected from getting malaria. Unfortunately for the sickle cell patients, the double S are very vulnerable to getting severe malaria. The reason is genetic in the sense that the hemoglobin had to mutate so that patients can survive malaria. So the carriers, the AS, are protected, but when an AS marries another AS and get a child with SS, then that child is at risk of getting severe malaria. So yes, there's a link. Also, patients who live in malarious regions are the same patients who live in the sickle cell region. So sickle cell and malaria actually are found in the same geographical region. The number 3, patients with sickle cell disease need malaria prophylaxis, as we've had, because they tend to get severe malaria. Unfortunately, these drugs are available, and so they end up getting repeated attacks of malaria, and probably most of them end up dying because of malaria. Yeah, so there's a clear linkage, and they join at the hip. Thank you.
Thank you, Nathan, for that. Gura Emmanuel is a public health officer and has had real big challenges convincing people to donate blood. And I think his question has been answered earlier. There are religious and other structural barriers for making people willing to donate blood. And Gura Emmanuel, we share with you your challenge. You have tried to talk to many people to donate, but they haven't. We know we have to do a lot in communication. There is misinformation, there is stigma, there could be structural barriers, religious barriers as well. So I would like to now ask Nelson Washira to unmute. We would like to thank you for your participation. You've been an active participant. Feel free to unmute your mic. Please introduce yourself and make a 1-minute stage comment by yourself. Nelson, the floor is yours. I know you've unmuted, but I don't think we can hear you. Nelson, are you there?
Amit, can you hear me?
Now it's clear. Go ahead, Nelson.
Okay, perfect. Now, my name is Nelson Washira. I'm a final year undergraduate at KISS University, pursuing BSc Microbiology. I have strong interest in public health, MR, and global health. Now, this forum, I think this is one of the best webinars I've joined today. Today I had 3 webinars on matters malaria-free Africa. And I think this is one of the issues that is mostly overlooked when it comes to shaping the elimination of malaria here in Africa. And I'm glad some of the experts in the room who have a ton of experience have been able to give me insights on some of the questions that I've raised. Now, the next webinar that I'm having, the topic is on the role of philanthropy. Now, I just want to bring about two final questions. Because when it comes to initiatives, we need to talk about money. So how does the availability of lack of funding impact this initiative? And lastly, as we wrap up this insightful webinar, are there opportunities for the youth involvement in championing for this cause? Otherwise, it has been really educative. I'm really glad I've joined this webinar, and I'm looking forward probably to partnering with you in the future. Thank you.
We really applaud you. We can feel your passion. We can see it coming through these super questions. And many people have asked many questions. I wish you all the best in your final year. Please drop your email to Caroline Wangamati. We would like to contact you and stay in touch with you after the webinar. And,
okay, sure.
And as you have cleverly just mentioned about philanthropy, I want to pass it to the chairman of COBA, Nathan Mulure. You really, I mean, the funding is a barrier, and we need the right amount of money at the right time in the right place. Large institutions like yours, which are multinationals, have done so much, and many companies here and many organizations. Before I turn it over to Hannah to talk about the youth that you guys are so passionate about. So Nathan, over to you on Nelson's question on money barriers.
Yeah, thank you very much, Nelson, for that contribution. Yes, indeed, funding is a big issue for blood. Practically, many blood centers are relying on the government to fund them on their checker, and sometimes that funding is not adequate, and that even limits the amount of blood that can be collected by the government health blood donor services system. So it's a big issue. There's no money in many African governments. There's look at health budgets, they're 4% of the required amount of money that needs to be put in place for health system. So the health sector is completely starved of cash, and that affects a lot of other segments in the health ecosystem. But again, we need to become innovative. We cannot, fold our hands and say there's no money. So let us wait and see what happens. Actually, we need to be very, very innovative. One of these is actually trying to build sustainable systems in the blood service. Sustainability needs to be factored in as people design blood services. And what we found out is that if blood is of good quality, through automation, I think, is one way of increasing efficiency. So increase efficiency in the sense of collecting the blood, in the sense of transfusion. Again, moving away from whole blood transfusion to components, for example, platelets or RBCs. Again, it basically increases the pool of people who can actually donate and those that can receive. So instead of one donor only serving one patient, if you do componentization, then one donor can serve up to 4 patients. So that again increases efficiency in terms of blood service. The other issue is trying to make the blood service self-sustaining and also income generating. It's a common adage that blood is supposed to be free, which is good. So free blood taken freely from donors and given freely to the patients. There's the other aspect of now manufacturing of blood components, especially plasma-derived components or medication. The immunoglobulins, for example, that we spend so much money importing, the IgGs and all these immunoglobulins can actually be processed if the blood quality is good. They can be manufactured and even sold to raise income for the blood centers. So as we talk about sustainability, moving towards automation, there are very many accrued benefits that will come from this discussion. At the end of the day, having blood, processed into blood medicinal derived products that can be sold and help the blood ecosystem become more sustainable. Philanthropy, yes, there have been donations from people like, groups like PEPFAR, for example, have supported through the HIV ecosystem, supported the blood centers in many countries in Africa, but this funding is going down. So countries need to wake up and really look at what other innovations they can put in place to make themselves sustaining. So good quality of blood, reduction of discard, the whole journey of blood in terms of getting blood that is good quality from the patient as well, blood processing, blood treatment. There are things now that are called pathogen reduction technology, so that if blood has, for example, it's contaminated or infected, this equipment can actually reduce the amount of pathogens in the blood and make blood safer. There's a whole array of innovation that can be looked at to make blood, of good quality, available, and also accessible to patients. Thank you.
Thank you, Nathan. That was really a good intervention. Let me move it to Hannah. Nelson Washira talked about the youth and the importance of youth.
Yeah, thank you. Thank you so much, Nelson, for that question. Before I tackle the youth question, let me just also add to what Dr. Nathan spoke about the funding. I think it's also important to talk about domestic funding and domestic financing. when it comes to sustainable interventions. And I think and this is something that we also try to advocate at every level at Africa CDC, to work with our member states, with the ministries of health, with the ministries of finance, so that this is at a level of importance where countries are committing some of their fundings to these areas as well. When it comes to the youth that we spoke on, I think over 70% of African population is youth. So it would be a waste not to use our youth very properly, because they're yes, it's a majority of the population is youth. And at Africa CDC, we have the initiative, what we call the Bingwa Initiative. And this is where we have mobilized youth as champions to increase uptake in the COVID vaccination. And we've done this regionally and at a national level. And the idea that we have behind it is to utilize this mobilized youth beyond COVID, and to utilize them in the fight, and to as champions to advocate for the different diseases and different challenges that we have in the continent. Yes.
Thank you. We'll be reaching out to the Bingwa Initiative now and loop them into the blood initiative and activities. So Caroline, please take note, and Samira, we have a link to the youth, but it's a very important question. I want to come to parting shots before we go to call for action, and then we will make some announcements, and we're coming to the end. So let's really talk about the parting shots and come to the end. Let's go backwards. Let me go from this slide. I'll go anti-clockwise, starting from Millicent, and ask everybody to give their parting shots in that. So Millicent, just 1 minute of a parting shot. We'll give everybody a floor as we wind up.
Okay, thank you so much, Dr. Amit. It was a wonderful discussion, and also wonderful time on the call. My parting shot would be: no child should die of severe anemia secondary to severe malaria and sickle cell disease. And there is need to improve availability and accessibility of blood to grassroots healthcare workers in the healthcare system. Thank you.
Thank you. So good. Angela, I'll come to you next.
Thank you very much, and thank you for hosting this webinar today. I think it's been very informative. I think even though from a diagnostic perspective, I really feel like everybody, all the panelists and everybody that was on the webinar today, I think something that has been brought to light is education. And I think it is really, really important that that falls on us as private companies, as organizations like COBA, clinicians. We need to start educating the public, and as it's been said, at the grassroots levels as well, to be able to get that education out there as far as blood supply is concerned, get the education out there for malaria, specifically with it being Malaria Day tomorrow. So that's sort of my parting shot. Obviously, diagnostics for me is very important, and it should be leading the way. But I think it's a responsibility for all of us to take on that action to educate and to be part of the education circle.
Great, thanks. Why don't I go to Harry Mapesi next?
Yeah, I think also from diagnostic point of view, I think for me, the fact that we have just signed the diagnostic resolution, I like when Hannah mentioned about domestic funding. So for me, I think one of the key home messages, how do we, for example, as from the private sector, work with the government, policymakers in the public sector, really to make sure we have partnerships or collaboration that can bring diagnostics to patients in the rural area. So that will be my shot, and I really want to thank Koba for inviting me for this webinar and for this opportunity. Thank you so much.
Absolutely. Thank you for dialing in, Harry. Let me go to Dr. Joseph Mulenga for his parting shot. And thanks for dialing in from Zambia.
Thank you so much for this opportunity. This is a great way of very interactive. I was just talking to my team here. Say, instead of traveling, miles and miles, flying all over the world, this is really brought, closer exchange of information in a very interactive way. And for me, I still feel after this webinar that bring out the complexity in access to blood testing, especially when you focus on malaria and the resources that are required to actually run an effective and safe blood testing. If we, for example, this issue of testing blood for malaria before transfusion and just the complexities of it, in my view, we should be targeting malaria elimination, campaigns. If that is missed, that is one end of the spectrum. The other end is pathogen inactivation. So if we have these two ends well done, I think we'll not be worrying about transmitting malaria into our patients. Anything in between these two ends is a compromise. And it's very, very difficult to introduce testing for malaria, the costs associated with it, the guidelines, protocols standardized across everywhere. Prophylaxis, again, in the patients on the bedside, the anti-malarial, the resistance that has been referred to. So for me, I think if we start missing the point of focusing on what we should be doing, I think we should be, as a form of therapy, as a form of supportive therapy, we should be saying it's benefit versus risk. Like all medical interventions, there are always side effects. We should not shy away that we are going to have zero risk in blood transfusion. We should say, yes, there are huge benefits, but there are also some inherent risks, so that we don't divert resources to what I think elimination should be one, and then pathogen inactivation, and then deal with the compromise the way it is, in between. In endemic areas, I've never heard of an upheaval in the wards that there is a rampant transfusion of malaria or reactions from doctors. That has never come to my attention. I don't know if everyone has any such upheaval, that there is a really very serious threat as a result of not testing for malaria from the clinician's perspective. I think they are more worried about children dying, and probably they can deal with the symptoms and all the adverse events. Probably we should be strengthening immovigilance system to look at adverse events or transfusion across the entire value chain. Thank you.
Thank you. We take home elimination and pathogen inactivation. That's a really underlying statement. That Hannah, can I invite you to just give your parting shot before we call in Nathan Mulure?
No, definitely. Thank you, Dr. Amit. I think it's been a very wonderful webinar with very rich discussions. I think my parting note is to collaborate, to forge partnerships so that we synergize the different efforts that exist, to use the different resources that we have at the continent, whether it's the community healthcare workers that we have, the youth that we have, so that we raise awareness and we have impact that saves the lives of our people. Thank you.
Thank you so much. Caroline, Samira Kibacha, Bildad, Ruth, the whole team, you can put on your cameras. I want to thank you all for all the support. Caroline, you are a blood ambassador. We wish you all the best. The work you're doing, you're leading COBA, the whole team behind the scenes that's made this happen. I also want to thank all the people who've asked questions. We can't attend all your questions. We've tried as much as possible. Some of the questions, if you feel you want us to communicate with you, we will communicate with you, and we will be led under the COBA model and the structure with our chair. I want to bring in Dr. Nathan Mulure to give his parting shots, and he will give us his call to action before we make the final announcements as we close the webinar. Please welcome Nathan Mulure on stage.
Thank you very much, Dr. Amit and team, for this very, very good discussion. on blood and malaria. I think it was long overdue, and really happy that I was able to participate in the discourse. My parting shot basically will be in various points or segments. And I think what we need to do is to continue to agitate and make noise. Make noise so that blood becomes central in health system strengthening in every country. That blood is given the seriousness that access to medicines is getting. Access to anti-cancer drugs, access to anti-malarials, access to cardiovascular medicines, that same light, that same torch that is shining on those other disease areas must also shine on blood. I think it's a good step for us to start taking and really make noise at all levels, at every opportunity for blood to be central or looked at as central in health system strengthening. Remember that WHO put blood as an essential medicines product in the 1977. To date, it is not there by definition as essential. It is so scarce, it's so unavailable. Let us make it more available. Also, to put blood on the global health map. Blood has not been there in the global health. Global health has been other antimalarials, for example, or HIV or hepatitis. Blood needs to be also on the global health agenda. Number 3 is to increase sustainability, increasing blood supply, increase innovation to ensure that blood is adequate, it's donated in a good manner, in a safe manner, is properly treated, properly stored, componentized, and properly transfused. And then funding also for blood, again, innovation in funding. We can link blood and climate change very, very easily. There's climate change funding all over. If we can be innovative and do proposals that actually help to address that climate change agenda from the point of view of blood, we can get more funding for this to happen. So my call is to increase innovation in terms of blood donation, blood transfusion, blood testing, and even funding for blood to be able to be available and adequate in our healthcare system. So parting shot will be to increase advocacy. That is the work of COBA. Make noise, as much noise as you can make at all levels, and let blood be seen to be everywhere and centrally in the healthcare ecosystem. So thank you all for coming for this very, very insightful seminar and webinar, and looking forward to many such. And thank you, CDC, for your great collaboration. You're going to be our pillar as we permit these organizations and discuss with them. Thank you. Back to you, Amit.
Thank you, Nathan, and definitely the pillar. And we've got a very nice technical expert in the pillar at Africa CDC. So Hannah, we're going to be contacting you. And my call to partners who are attending and panelists who are here, and every stakeholder, join COBA. Later on, the last minute, I'll ask Caroline to just have a goodbye for us from COBA. But let me make 2 announcements. Next slide. I just want to make 2 announcements, and then I'll call in Caroline to really say you can become a member of COBA. You can also become a strategic partner of COBA. We have a website. We have an event coming up in May 23rd, and we're going to talk about the new dawn of partnership for women's health. It's in Accra, Ghana, and I know Agnes is from the Ghana Health Services, and I'm really glad that you could join us, Agnes, from Ghana. Agnes Ompofo Agay. So we talked about maternal health. Save the date. That's one. And the second announcement. Next slide. Is about the CPHIA that we spoke about earlier. And this is the 4th International Conference on Public Health in Africa, taking place in Rabat from 26 to 29. And in this, we'll probably have the Africa Blood Forum. That was it from my side as closing remarks. Caroline Wangamati, I'd like to bring you on stage here, as you can say bye before you go to the music. You just...
Thank you so much, Dr. Amit, for wonderful moderation. I want to thank our wonderful panelists. The Coalition of Blood for Africa invites all of you to join us. I know quite a number of you, the panelists, your organizations are already members. Some of you are already in conversations. For the blood services that were here, Dr. Mulenga, we're looking to partner with yourselves. For all the other entities, private sector, government, we're looking to partner with you. But more important, we're looking for that stewardship from Africa CDC. And Hannah, we want you to convey our thank you to Dr. Mohammed, because you're already in discussions. We've already put our concept paper on your desk, and we will be discussing further to see what difference we can bring to the blood landscape in Africa in collaboration, and having you as our leader championing the way forward to make sure that it saves lives. So to reach out to us, our email is right there on the screen. Samira is my colleague, eskibacha@africahb.com. We are nice people. Call us. We'll be happy to talk to you, give you more information, and let's work together to make sure that we don't lose any life to the lack of blood. My gratitude to our moderator. You've been super. Thank you, sir, our chair. I truly appreciate you.
Bye, everybody. Thank you for your time. Bye.
Thank you very much.
Thank
Bye.
you very
Goodbye.
much.
Thank you.
Goodbye.